Hi, my name is Miriam Alice Fora. I'm an internal medicine resident at the University of Miami, and today I'll be presenting a rare case of metastatic cutaneous squamous cell carcinoma that presented to us with symptomatic anemia and hypercalcemia. I thought this case was worthy of reporting because we rarely see cutaneous SCC metastasizing to other organ systems, and only a handful of cases have been reported. More importantly is that non-melanoma skin cancer incidence has been on the rise in the past decade and currently compromises 1/3 of all malignancies. So let's move on to our case. A 60-year-old male presents to ED after being sent by his PCP for treatment of advanced skin cancer. He reports that approximately 10 years ago, he noticed a skin lesion under his left eye, and he went to a dermatologist who removed it via cryotherapy. Over the next couple of years, the eye lesion reappeared, and he developed other skin lesions in his left forearm, left axilla, right shoulder, and upper back. He wasn't following up annually with a dermatologist at the time and had limited access to healthcare because of financial issues. Those skin lesions progress to become large masses that frequently bleed with minimal contact and now have whitish discharge. He also noticed he was becoming progressively fatigued, experiencing decreased appetite and weight loss. His functional status had especially declined in the past year to the point where he's almost bedbound, so he presented to another hospital where he was admitted for further workup. He doesn't have any of his medical records and doesn't recall the diagnosis he was provided with, but reports that his lesions were biopsied and surgical resection was offered for the eye lesion. He declined treatment because he did not have medical insurance and subsequently presented to our center since it was a safety net hospital. He didn't have much past medical history except for gout and osteoarthritis of the knees. He doesn't take any medications and he doesn't have allergies. In terms of his family history, he's not very familiar with that because he was adopted. And for his social history, he had alcohol use disorder but quit 1 year ago. Currently, he's unemployed and lost his health insurance more than 15 years ago and is in the process of obtaining Medicaid. For review of systems, he has a 45-pound weight loss in the last 5 months and severe generalized fatigue. Moving on to physical exam, vital signs were within normal limits. His ECOG performance status was 3. He appeared cachectic and frail. He had generalized muscular atrophy and left arm edema up to the elbow. For his skin exam, please refer to the images here. You can see multiple skin lesions, a hyperpigmented lesion under the left eye, and a large fungating mass in the left axilla and forearm that were bleeding with purulent discharge and foul smell. He also had a fungating black mass in the right shoulder, as you can see, with hemorrhagic crests. Furthermore, he had multiple smaller lesions on the abdomen and back and several satellite keratotic papules, but no lesions in the lower extremities. And for the lymph node exam, he had enlarged hardened lymph nodes in the left axilla. His lab showed leukocytosis with a white count of 18, anemia with a hemoglobin of 7.4, and hypercalcemia with a calcium of 11.3. Wound cultures grew Staph aureus and Klebsiella, and biopsies of the skin lesions showed basal cell carcinoma nodular type of the left inferior eyelid, and keratinizing well-differentiated squamous cell carcinoma for the left arm biopsy. Now, if we look at the CT images here, it demonstrates enhancing mass in the left axillary region measuring at least 10 by 12 centimeters, and enhancing soft tissue mass measuring 7.5 centimeters in the left distal arm, which seems to be an extension of the axillary mass. And finally, we have a hypodense irregularity of the anterior aspect of the first left rib measuring 3.3 centimeters. So we basically have a 60-year-old male presenting with metastatic cutaneous squamous cell carcinoma resulting in leukocytosis, hypercalcemia, and symptomatic anemia complicated by wound infections. Imaging showing large masses in the left axilla extending possibly to the left arm as well as a left rib lesion. He was transfused for the anemia, started on antibiotics, and wound care were consulted. Oncology were consulted too, with subsequent outpatient referral to start combination cisplatin-based chemo and EGFR inhibitor cetuximab. So the lessons to be learned from this case is that distant osseous mets and cutaneous SCC is rare, with very few case reports published. Such reports postulate that bony involvement is driven by a perineoplastic process and the release of PTHrP by tumor cells. EGFR inhibitors such as cetuximab in combination with cisplatin have demonstrated benefit in prolonging survival for SCC of the mucosa, but the potential benefits for cutaneous SCC remain unknown. Anti-PD-1 such as semolizumab and pembro are also other treatment options, especially with failure of first-line therapy. And cutaneous SCC should be risk stratified at diagnosis to determine which patients are to be more closely monitored for recurrence and also for aggressiveness of therapy. Thank you for listening.